All right, wonderful. Thank you so much. And thank you all for joining us today. I appreciate seeing y'all introduce yourselves in the chat. I see we have folks from all across the country. I saw California, I saw New York. So from sea to shining sea and maybe some territories as well. Really wonderful to see. So please continue to do that. My name is Dana Flightman. I'm the Senior Training and Awareness Specialist at SPARC, the Stalking Prevention Awareness and Resource Center. And today we'll be talking about stalking of healthcare professionals. This is primarily a roundtable discussion, but I couldn't help but start us off by talking just a little bit as the training specialist about what this project is, what stalking is, before we get to the meat of the conversation. And I'll introduce our panelists who will take it away in just a couple of minutes. So, SPARC is funded by the Office on Violence Against Women, and we have a couple grants from them. This specific webinar is actually brought to you by our Vital Signs project. So I'll go back to that. Vital Signs is about enhancing the healthcare response to stalking. And so if you're familiar with SPARC, you know that our job is to help the helpers. We provide training and technical assistance to multidisciplinary professionals around recognizing and responding to stalking. That includes folks on the victim services side, the criminal justice side, anyone in between and beyond. But one group that we weren't able to reach quite as much were healthcare providers who, of course, are so often part of a coordinated community response and who play such a critical role in addressing the Violence Against Women Act crimes, of which stalking, as you might recall, is one. There are four major crimes under the Violence Against Women Act: domestic violence, sexual assault, dating violence, and stalking. And so we're really excited to be developing more resources for the healthcare provider community. And primarily that's really looking at healthcare spaces as a potential entry point for our victims and survivors. So recognizing that victims may seek out medical care in addition to or in place of perhaps reporting to law enforcement or directly to victim services, especially with a victimization like stalking that's so under-resourced. We always want to remember, despite its prevalence, there is no stalking hotline. There are few, if any, stalking crisis shelters. So it really falls to folks like you on the call, as well as folks like our panelists, who are often primarily focused on other tasks, other kinds of care, and likely have more training and background in other victimizations, like intimate partner and sexual violence, to kind of add stalking on. And so at SPARC, our job is to make that, I won't say easy, but as easy as possible. So we've recently come out with some resources around the health impacts of stalking, in which it has impacts on mental and physical health. So we have a new video to that effect, as well as a fact sheet infographic. We're developing screening questions and a brochure that you can use in healthcare spaces to identify if patients are experiencing stalking. So those will be out soon, and more ongoing webinars, resources, tools. And so that's, again, primarily with the goal of helping healthcare providers better serve victims or survivors of stalking. But something that's also come up for us very clearly in our early stages of the project is that healthcare providers themselves are more likely to be victims of stalking. And that not only are they responding as those helpers, but they also may be victims as well. And we're seeing that the unique ways that stalking presents in healthcare spaces. And so that's really our focus today, is just shining some light on that intersection and how our healthcare providers can also be victims of stalking, and what our victim service providers and criminal justice professionals can best do to identify and serve those folks. So all the resources I'm mentioning and more are at our website, stalkingawareness.org, and my colleague Kendra is in the chat sharing these as well. There we have practitioner guides, and those are broken out by discipline. So we have a section for healthcare providers now, again, under our Vital Signs project, as well as for victim services, law enforcement, prosecution, awareness educators, judicial officers, and more. We have training modules and materials. So if you do any kind of community education around health, consent, bystander intervention, you want to be talking stalking as well. So we have scripted programs you can pick up and lead, infographics, fact sheets, awareness materials. victim resources. So we are not a direct service provider at SPARC. So please don't send stalking victims to us for anything other than general information because we'll just have to be nice and send them back to y'all. But we do have resources that you can easily share with victims. So for example, we have these brochures you can order from our website in English and Spanish on understanding stalking. And again, a health specific one's coming soon. And so and we also have handbooks with basic stalking information that are printable, documentation logs, all of those are in multiple languages. So if you have something to hand your survivor of intimate partner or sexual violence, make sure you have something for your stalking survivor as well. And webinars like this one. So if after this you're like, ooh, Dana only talked for some of the webinar instead of the whole webinar. I wish I could hear her talk for so long. You are in luck because we have an archive of recorded webinars and we're called SPARC, so I got us to call it the SPARchives. So that was like the height of my career. So you can check us out on the SPARchives anytime and follow us on social media. Our handle on there is at Follow Us Legally. If you get our sick sense of humor at SPARC, we want you to follow us. We won't be scared unless you act out and sign up for our newsletter. As an anti-stalking organization, we will not contact you excessively or without your consent. So you have to actually opt into our newsletter, and it's one we send around quarterly. So I hope that you will stay in touch with us for more resources under the Vital Signs Project, as well as others that might be helpful in your work. So a quick overview here when we're talking about stalking and healthcare professionals, just to introduce some of the themes that I know you're going to hear much more about in just a couple of minutes. Of course, we want to remember that stalking is criminal, traumatic, and dangerous. It's a crime across the United States at the federal level and in all US territories. Stalking is traumatic with both mental and physical health impacts, and stalking is dangerous. It's not just annoying or frustrating, it often intersects with physical violence, sexual violence, as well as homicide. When we're talking about what is stalking, well, of course, depends. Are we talking about our statute or are we talking behaviorally? It's good to look at your statute. We have a map on our website where you can look into that from a criminal justice perspective, but we're really talking behaviorally today. Like, what is stalking? What does it look like? What does it mean? And so, behaviorally, stalking is a pattern of behavior directed at a specific person that would cause a reasonable person to feel fear for their safety or the safety of others, or to suffer substantial emotional distress. So it's a pattern of behavior that's two or more behaviors. And those behaviors can be quite varied. They often include crimes on their own, like, say, property damage, with other behaviors that may not be crimes on their own, but can become criminal in the context of a stalking case. For example, texting excessively or showing up at someone's place of work or home. So it's two or more behaviors that would cause it's directed at someone specific. So it's not random. It's not someone looking at a group of people in a locker room. That might still be a crime, but stalking is directed at someone specific. That being said, we often see what we call target dispersion, which is our stalker might look for people close to that victim to try to get information and access to them. And so if say the patient is a stalking survivor, you could see them trying to reach out to, say, the healthcare provider to try to get those records and information, et cetera. And it would cause a reasonable person to feel fear and or suffer substantial emotional distress. So fear is really important to understanding stalking, and behaviorally, it's what separates it from harassment. It's that fear of bodily harm, fear that someone else will be hurt, as well as emotional distress. And emotional distress is not just having a bad day or being frustrated. It's really feeling that you cannot live your normal life because of the interference from the stalker. So, like, a powerful quote I saw from a victim was said, "It's like he's taken my life without killing me." So that sense of I am under surveillance, my life is being invaded, I'm being sabotaged, I'm being threatened and intimidated. I cannot live a normal life, even if I may or may not be worried of physical harm. Stalking's prevalent. In the United States, nearly 1 in 3 women and 1 in 6 men experience stalking victimization in their lifetime. So this prevalence is quite similar to intimate partner and sexual violence, which also are important issues that need a lot of work and help, but have a few more than stalking does. And like I said, health professionals are likely to be victims. Now, research is limited and around prevalence, but multiple studies are suggesting that a variety of medical professionals, including some that we have on this call, are experience higher rates of stalking than the general population. Those may be patients who become fixated on a medical provider, or just like in the general population, since most stalkers know their victims, most victims know their stalkers, it might be a current or former romantic partner or other kind of acquaintance who is then targeting that person in their workplace. I want to say up top that we know most stalkers do not have significant mental health issues, any sort of significant psychosis, bipolar, etc. However, while that may be a small percentage of stalking offenders overall, that population is more likely to encounter our health professionals, right? If they're in treatment for whatever their condition may be. And so we know that our healthcare providers are more likely to be in contact with that minority of stalkers. And in terms of why this is happening, again, our panel will talk about it in more detail, but our studies are showing it could be both the nature of the work and the expectation about their engagement in the relationship, kind of the expectation of care, the sense of personal connection people have with healthcare providers. Some challenges that we'll explore: the ethical guidelines. Our doctors and medical professionals of all kinds, they want to avoid harm and they want to maintain patient confidentiality. And that can make it really tricky if a patient is harming that medical professional. A lot of organizations lack well defined procedures and workplaces in general, I would say, but certainly our healthcare spaces as well, on how to manage stalking. And it can be difficult to know what is clinical versus what is criminal. What's the line at which I should raise an alarm about this to a supervisor or somebody else? And so, that all being said, I'm excited to bring up today's panelists. Our goal is to have a facilitated dialogue. And so that means I will be interrupting them, calling upon them, etc. So they're prepared for that. So don't think I'm so rude, hopefully. And so we have four fantastic panelists today that bring such a wealth of expertise, knowledge, in their current settings, in past settings they've worked in, etc. And so I'm so delighted to have them introduce themselves to you. So, Jordan, if you could say hi to the folks on here and introduce yourself and explain what is your role and what kind of perspective do you bring to this dialogue?
Hi, everyone. My name is Jordan Bentley. I live in Florida, the Sunshine State. And my experience is I am an advanced practice forensic nurse where I specialize as a SANE A, which is a sexual assault nurse examiner for adolescents and adults. I'm also a telesane, which means that I am administering consultations to do medical forensic examinations through a telemonitor, specifically in rural areas for patient populations. But my passion for the nursing field is always and has always been psychiatric services. I am a board certified psychiatric mental health nurse, and I'm also an educator at Galen College of Nursing, where I specifically teach mental health to different programs within every single nursing capacity.
Right. Wonderful. Thanks so much, Jordan. All right, Ben.
Hello, everyone. My name is Ben Fox. I'm a licensed mental health clinician in the state of Vermont. I'm a program and clinical director of a small nonprofit equine therapy site. I've been doing mental health work for over 17 years, and I am both a survivor and victim of stalking by a former client for over 10 years. So I appreciate being here and the services that SPARC offers.
Thanks so much, Ben, and thanks for sharing that with us. All right, Ralph.
Good afternoon, everybody. I'm Ralph Riviello. I'm an emergency physician and currently serve as the chair of emergency medicine here at UT Health in San Antonio.
All right, great. So thank you all so much for joining us. Here I'm going to close out our slides here so folks can see your faces, and I'll ask my first question, which is, why do you think healthcare professionals are vulnerable to stalking? Yeah, what do you think are some of those vulnerabilities? Not all at once. Okay, calm down.
So I'll take the first step. I think a lot of it has to do with the work we do. So, a lot of us take care of patients, sometimes during very difficult situations, often in emergency departments, mental health facilities, private counseling, that kind of stuff. And I think people either, interpret something during that interaction or misinterpret something during that interaction. And I think it depends then what the stalking is based in. Is it, I'm stalking you because I'm romantically interested in you or think we could have a romantic interest? The other thing about it would be, am I stalking you because you didn't take care of me in the way I thought I should have been? Maybe we didn't prescribe opioids for a condition that the patient wanted opioids in, or maybe we denied them something else that they thought they needed when they came into our treatment. And I think that kind of sets up the behavior of, I'm going to stalk you. I'm going to make you know I'm out there. I'm going to bother you. And I think those are some of it. And then I just think, the normal risk of being stalked from domestic partners, former love interests, et cetera, is just always there. I think that's just the baseline that we all have as humans. But I think some of those work relationships put us at a little bit higher risk.
No, thank you. I think that's such a good insight. I'm seeing a lot of folks nod along here. I'm interested in that. It seems like you approach it, well, what's the stalker motive? And I know we always say it's hard to know stalker motive. When you read a text message that says, I love you, I miss you, I hate you, I'll kill you. I'm like, what were your goals? And it can be so conflated that romantic pursuit and then I'm punishing you and then back. But I think that perspective of they didn't get, they didn't get the kind of care they wanted, and so now they're stalking. Have other providers seen that kind of dynamic?
Yes, I would say so. And from the nursing perspective, I would say a lot of the times nurses are subjective to stalking and violence because we're spending the majority of the time at the bedside with those patients. And whenever you factor in different vulnerabilities, such as mental illness, when we're talking about mental illness, they can have different issues related to fear, abandonment, trauma. And us nurses at that bedside, we prioritize safety. And we're trying to make our best clinical judgment to provide that safe place for those patients. And a lot of times it can be misconstrued as to something else.
Yeah, I can agree with that, Jordan. And I didn't get to introduce myself, but I'm
Oh my
Lacey
goodness,
Smith.
I'm so sorry, Lacey.
That's
How
okay.
rude of me. I'm so sorry. Please do so now.
That's okay. I didn't even realize I didn't get to introduce myself until after we had already moved through. I'm Lacey Smith. I'm a forensic nursing specialist at the International Association of Forensic Nurses. So in my clinical practice, I'm a sexual assault nurse examiner. But prior to that, I was a pediatric nurse. And I think, we're talking a lot today about stalking by patients, but an important thing to consider is that we healthcare providers, clinicians may also be stalked by patient family members. In the pediatric world, we do a lot of work, not just with the patient, but with the parents or the caregivers, the family members, the loved ones that are there. And, when we have a child or even a patient in an intensive care setting that is in the hospital for an extended period of time, we may care for that patient multiple days in a row. And then, our next week of shifts, we may be caring for them again to, keep a continuity of care. And then we create relationships with the patient, with family members. And it's so important that we are maintaining those professional boundaries, right? I think clinicians specifically, from the nursing perspective, we're very empathetic humans. We want to create those relationships with our patients so that, they know that we see them and we hear them and we want to take care of them, but we really have to hold those professional boundaries because when we don't, we're opening ourselves up to this kind of behavior that may be negative and that may put us in situations that are unsafe. And some other things that I thought about that make healthcare professionals particularly vulnerable is our empathetic and caring nature. We also sometimes feel like we don't really have a choice in this type of relationship. We're there, we're doing our jobs, and sometimes we put up with a little bit more than maybe we would outside of our professional setting. And, maybe it doesn't raise the red flags because we're like, oh, we're working and we're not thinking about all these behaviors that may not be the best kinds of behaviors that are coming from a patient or their family member or loved one.
Yeah, absolutely. I think that's such a good point too, that of course, when you're providing care for someone, it's not often not just them, right? And that there's all these other folks who are invested in that care who may also become a risk for this. Anything else folks want to add around why healthcare providers might be vulnerable?
And I might add, Dana, that even if we are providing that care with the best of our ability and our boundaries, often it still occurs. It may occur after a treatment episode without us even being aware of it. And given the systems that we live in and work in, access to our own support and care might put myself and the people I'm working with at risk because there aren't enough healthcare providers out there or support systems out there to say, oh, that might be a problem. Let me help you with that. And that criminal versus behavioral clinical issue continues on until it gets to a point where, oh my gosh, this is a real red flag. So we put up with it, Lacey, for a while, right? Until someone else goes, hey, wait a minute, what are we talking about in supervision? This is really something that needs to be worked on right now. That might be going on for a long time with someone without them even knowing it.
Yeah,
Yeah.
I'm so glad you raised that. Oh, sorry, Lacey, go ahead.
Yeah, I was just thinking sometimes kind of hard to see the forest for the trees, right? We're in that relationship with that patient, and we don't often recognize that there are multiple red flags, and someone else may be able to see the bigger picture and say, hey,
Yep.
this doesn't sound right.
Yep.
Yeah, I think that's such a good point. And of course, so many of our victims have that problem of minimization and, stalking's a pattern of behavior. Those individual behaviors often add up more to the sum of their parts. And so I can see how that would be especially difficult in a space where you're trying to provide care and give the benefit of the doubt and just do your job. That's such a great insight. Anything else folks want to add on that? Okay. And this has already come up a little bit, but of course, there are so many different stalking tactics. And I always say I don't mean it as a compliment to stalkers, but we know they are very creative offenders who will engage in a wide variety of often surveillance, excessive contact, threats, property damage, spreading rumors, stalking both in person and through technology, etc. So, what are some stalking behaviors or tactics that you've witnessed or experienced that could uniquely target or impact healthcare providers?
I think one of the ones I've seen, especially from emergency personnel, are the patients who show up when you're there. So I could give an example that we have a particularly difficult patient who we all, as a group of physicians, follow the care plan that we have set up for her. However, there is one physician she particularly does not like, and she seems to only show up on the night shift, and that particular physician works night shifts. It's statistically improbable that you would have a problem with your chronic medical condition only at 11 p.m. till 7 a.m. So that was probably something we didn't recognize as much until she actually started making a threat against that particular physician and verbalized it in an email and that. So it was probably years in the making. And then when you look back at it, you'd say, wow, that's probably stalking behavior. She shows up consistently on the night shift, knowing that's when the person she likes the least of my group works. So I think that's another problem, is that they sometimes take a while to recognize that this is a stalking behavior. Other things would be calling to see if that person is particularly working. You'll never know sometimes who it is making that phone call, but if your secretaries or whoever answers your phone say, gee, somebody's always calling to see if Dr. Riviello is here. Is that something that we should be concerned about, or that? So I do think it's sometimes hard, though, to really pick out the behavior unless it's beyond the healthcare setting, right? If somebody happens to be always where you are in the community or always at the, grocery store when you're there, that's probably going to alert you to it sooner. I think what Lacey mentioned, like we're there doing our job. We don't necessarily realize that, gee, they're always here when I'm here. But when it gets beyond the healthcare setting, I think is when we probably would notice it sooner.
Yeah. And I think too, as we think about shift scheduling and things like that. We are often, a lot of clinicians are on, a track schedule, and maybe you work the same 3 days on, 3 days off, 3 days on, 3 days off, and you always work the same shift. And it's really easy for someone who's interested in identifying a pattern to identify that pattern and then show up, when they think you'll be scheduled. I've seen that happen frequently. Patients that will figure out, what car you drive or what your normal routines are. And, I've seen patients that will, ride by the hospital or the clinic and, oh, well, there's their car. And, we don't think about things like that, and we hate to think that we as the healthcare provider might need to kind of change up our routine sometimes and, do things like that. But something to think about, that especially, for those people that are making those schedules, trying to make sure that we're not, if we're having these kind of issues that are popping up, maybe we need to rethink using a track type system and, things like that. Having some kind of, variation in place might be helpful.
If I may, I have experienced stalking both in the office and out of the office, leaving things in my office, coming to my office when I'm not there, talking to colleagues, stalking by proxy online, monitoring where I am, what I drive, what my family drives, where they are, talking to colleagues that I work with, talking to people that I associate with in my community, that I go to church with, where I shop, where I fix my car. I live in a very small place. My stalker knew where I was all the time and still does. And so all of these things affect me. I think for me, I might have, without the systems in place to really recognize and have support to start to cope with it, I sort of shoved it away. And it wasn't until later on when I tried to get a restraining order, my lawyer said, "You've been adjusting your life in many ways that I hadn't really even recognized that I've been doing. Driving an hour to the grocery store when there's one 5 minutes away." So it really is invasive to all areas of life. And trying to then explain that small behavior to someone who says, "Well, there's a note in your office, somebody left it there." To them, that's just a note in your office that someone left, not, "Oh my gosh, my stalker was here when I wasn't here, and it's a threat to me because they were watching me from the parking lot."
Yeah, I so appreciate that, and also your willingness to share what you've experienced, which of course is so upsetting to hear. And I appreciate you being on here and your bravery and sharing what you've experienced, knowing that there is an ongoing victimization happening here. But yeah, I'd say I'm so glad you brought up that the contextual nature of stalking, that, a note in the office, just a secretary saying there was a note left in your office, that may not sound scary to an outsider. But when you look at the context of this particular stalker has been showing up, threatening, they knew I was gone. That's when they left the note. How did they get in here? What did it say? Right? When you zoom out at the big picture and look at all those behaviors, it can become really scary. Are there other contextual behaviors like that might be particularly threatening to healthcare providers that maybe, say, a victim service responder not as familiar with healthcare settings may not identify as like, ooh, that's really scary?
I feel
But I'm
like I have faced a similar situation as to Ben. I was stalked for a little bit over 2 years. I was in a leadership role managing a psychiatric hospital, and I don't want anyone to think ill will on mental illness because we've come a long way to break down those barriers for the stigma. But it is very offsetting where a patient would show up at my car. He would be waiting outside for me. He knew the shifts that I worked at. I would do outreach events in the community. And because it was a public event, he would show up there. He would call my work phone number constantly. And because no one else really knew what was really going on, it was really hard to find that support. And because it was a mental health facility, he would act out in different behaviors constantly so that I would be the person to de-escalate the situation. So it became a very scary, very dangerous situation. I've had my own mental health repercussions from that. And in essence, sometimes you become disassociated. And then looking back at it, he had what we call transference. So transference is where a patient will unconsciously display inappropriate feelings onto you as their provider. And that could be simply because you remind them of somebody in their past. It just so happens that I reminded him of his ex-girlfriend. So he was attached to me like a leech. And unfortunately, in my community, I just did not have the support or even the confidence to kind of get out of that situation. And it was very scary.
And Dana, if I may add to this, I don't know how this falls in. My stalker went after my license and filed claim against my professional license, which other people in other professions may have something similar that they work under. I think in my particular case, right, someone filing a lawsuit against me saying that I'm a bad therapist, that's my livelihood. And yes, I got that letter in the mail. I got that email saying that you have not responded to this claim, and saw the name and called my health insurer, and they luckily had enough money to help me fight it, but it took a long time. I do think that's unique. And to add on to that, I'm still working in the field. I'm still supposed to be the therapist to manage the transference, to manage these things, and see someone the next day. It's not as though I quit the field to do something else. I'm still working in it. I'm still trying to have a family and a life, and I haven't relocated. My stalker and I live in the same community.
Yeah, I think that's a major fear for, any clinician that has a licensure to maintain. And I think a really big reason why sometimes healthcare providers don't report some of this, behavior that they're experiencing from a patient, and reasons why we're terrified of something like that happening. If we escalate this, if our facility has a policy about how we handle an inappropriate behavior, we're afraid if we escalate it and then it gets to the point of, a protective order or, some kind of law enforcement action that, you know, then there are these things that this patient can report to our licensure board. And, will we have the monetary resources to fight it? Will we have the time and, the mental capacity to be able to handle something like that? Because that, takes over your whole life. It's your livelihood. And it's almost one of those situations where you feel like you can't even think about anything else and you're still having to go and do your work. Like you said, I've seen, and I think in my own practice, the fear of having my last name on my badge. And, we want to be transparent with our patients, but when we're when our personal information is there on, the licensure board, on the internet, on social media, all of those places where easily things can be put together to find out, even if we don't have our last name on our badge. If you have a name like mine that's kind of spelled uniquely, if someone, you know, looks me up on Facebook, I'm going to pop up in a small community. And, even not having my last name may not be helpful. There are just so many, and those things are things that I've experienced where patients have, looked me up on social media, contacted me on social media, figured out, where my children go to school, where I went to school, those kind of community things that we're all doing when we live in small towns or in, rural areas, things like that. It's hard to not run into patients. And I think too, we as clinicians, we're concerned about our patients' privacy and confidentiality. And if they're, like Jordan said, coming to a community event and having these behaviors and making us uncomfortable, we often don't want to address it in front of other people because we know that, they're our patient and we want to maintain their confidentiality. And that is a whole other, cascade of problems.
And there's other long-term consequences of those repeated lawsuits or complaints against your licensing board, because a lot of times for a period of time they have to be reported. for hospital credentialing, other kind of credentialing, malpractice credentialing, et cetera. And, you know, you could have to explain it each time, potentially provide documentation if there's final outcomes that are adjudicated with the formal letter from any of the agencies or court records, et cetera. And it just gets to be very onerous on the victim to keep up with that and have to do it every single time. Even when you reapply for your board or your licensure every time, you may have to report that. So it may seem like, oh, of course, these are just going to get, dismissed or they're going to be looked at, but they're not. Everyone requires hours of preparation, meeting with somebody, writing the response, potentially appearing in person to the board to defend it or talk about it, the waiting for it, and then having to relive it all again. And when you have to bring it up for your future licenses or anybody who's maybe hospital affiliated or group practice affiliated that they have to credential with them every so many years. So it really could have a lot of effect just beyond the initial problem of the lawsuit or the board complaint and that kind of stuff.
Can I add to that, Ralph? Yeah, I basically had to give my entire client record over, which is the weirdest thing I've ever done, and had it read back to me and say, how come you didn't see this sooner and do something about it? So, there's the aftermath, and in the process of doing the care that we do, right? Thinking about, oh, how am I going to then, stand in front of my stalker or the
Right.
court or whomever, and then have to defend my actions, whether I knew what was happening or not.
Right. Well, so that's even more short-sighted on their part, as if, oh, wait a minute, you were really the victim in this, yet you were the one that were supposed to do something to stop it. Right. I don't think we do that for any other crime. Like, oh, why did you stop that carjacker? Why didn't you stop, whatever crime was being perpetrated against you? We don't do that. We do it to some degree to sexual assault, you know, survivors. Like, well, why did you do that? Or why did you go there? Or why did you wear that? But, it's interesting how, if you look at it from sexual assault, an often gendered crime, and, the blame is being placed there oftentimes on the survivor. Yet here, it is gendered to some degree, depending on the stalker, meaning if it was a romantic interest or ex-partner, etc. But, you know, this could happen to anybody, really, when you look at it from a work relationship or healthcare professional, yet you're still being blamed that you did something, right? So I guess in my example from earlier, what would it have been for the board if it got to that level to say, well, why didn't you just give her the narcotics? What would be the harm in that? Well, look at the opioid crisis currently in the United States. So, yeah, I guess I could have given her, her narcotic every time she comes to see me, but is that really the way I should have helped and protected myself? So I think, you know, the webinar here is great getting the information out, but like I doubt the people who adjudicate for the boards or serve on these panels or law, who are peers or even people on juries know this information. So it's very easy to say, why didn't you stop it? You should have recognized it. And I think we've already said why we don't recognize it. There's a lot of reasons in that.
No, I really appreciate that. And I think that kind of victim blaming, I see how it can uniquely, the way you're talking about it, how it might uniquely present for our healthcare providers. But I'm also seeing folks in the chat saying, like, I'm really worried about being searched and I change things to private. And all of that is completely reasonable behavior. You should be in control of what information you share or don't, and etc. That's all good kind of, risk reduction or what have you. But it's also good to remember, like, no one just like I sometimes I say at the risk of sounding a little bit twee, I feel like the what did you share has become the new what did you wear, where it's like, oh, well, if you didn't want to be found, why was that on social media? Or like, why did you have that profile on the hospital website if you didn't want them? And it's like, The problem is not that any information exists. The problem is that a stalker chose to misuse that to stalk. Now, that being said, you might absolutely, that might be part of your safety planning to take that down. That might be better for you. You know, you'd want to work with a victim advocate to make that individualized choice. But I do think that kind of victim blaming, that is certainly still a problem for other crimes like sexual violence. But as a field, my sense is that we're a little bit better at identifying it as like, hey, that's victim blaming. The same things are said to stalking victims and aren't always called out, that, you know, why weren't you clear you wanted it to stop? Why didn't you see this? Why didn't you do that? Why didn't you manage this better? You know, why did you send mixed signals? You know, that kind of thing. So it's interesting how that's presenting here. Yeah, Ben.
And I'm thinking of a different case, therapists who have moved their practice into their home, especially since COVID, and are doing Zoom. And a therapist who I was in contact with, someone started stalking them. She's in her home by herself. I mean, inviting people in either in person or through Zoom. Literally in your house. They know where you live. So we can dissociate ourselves on social media, etc. But I'm still inviting them into my personal space and trying to make it as comfortable as possible to build trust and work on a relationship that may have a lot of trauma. Some of that known, some of that unknown, that does transfer, and it could go very wrong very quickly. Yeah.
Do folks have anything else they want to add here before we move on a little bit? Okay, and this, we're already kind of talking about this, but what are some of the challenges that healthcare providers face in accessing safety and support? So we just addressed some of the victim blaming that can come from peers as well as superiors in a board or et cetera, of that. Why didn't you notice this? Why didn't you do something differently professionally with this patient and or identify it sooner? What are some other barriers that might exist to receiving the kind of care or help or support that you need?
Well, I think it's just knowing where to go even, right? So, if it isn't a ex-partner or that, I don't know that most people would think that they would go to a victim services agency. And then which one? Would it be a domestic violence victim services agency? Is it just a general victim service agency? Is it working through your police departments? Victim resource officer or victims resource personnel. So you know, I think that is part of it. But I do think what was already mentioned is key, that sometimes, working in a system or within a hospital or that, you sometimes are afforded a little bit more protection because there are people, at least if something's going to happen at the workplace or the stalking is occurring at the workplace, at least there's mechanisms in place to alert others, to have warning systems within the charting system. We're fortunate at my facility that we have an actual police department within our hospital, and it's actually the hospital's police department. So they are well aware of things like this and know when that person is on campus and know to be even more vigilant around them and to actually respond when that person is in our facility to the emergency department to provide support and protection. Now, that's probably not everybody else's norm, but right. But I think when you highlight the fact that, think about people who work in private offices or offices that might be out of their home or, you know, in isolated buildings, or, you think you're doing the right thing by having evening office hours, but nobody else in the building is there, or those kind of things. So I really think there's a lot here when you think about what we talk about, at least for our sexual assault and DV patients, of safety planning. I don't know that anybody's available to have that conversation necessarily with a stalking survivor who is a healthcare worker. And then sometimes you'd have to like totally alter your entire practice or your entire work life to make yourself potentially safer, depending on how it's escalating or what's going on.
Yeah, to your point of, is there even someone available to talk to for safety planning? I think, that is a unique opportunity for forensic nurses. If, a facility has a forensic nursing program or has access to forensic nurses, we are trained to do safety planning with patients. We may not always be the one that's doing the really detailed safety planning, but we do know how to do it, and there's lots of training and resources available. Those forensic nurses are that a healthcare provider could tap on their shoulder if they felt comfortable with that, to talk through some of this. And important, that we're talking with forensic nurses about stalking so that they're aware that this, victimization is different than other victimizations, and that we have those resources there in our facilities, that we know, okay, so we don't have a dedicated stalking hotline, or we don't have a dedicated shelter that we can call specifically for stalking, but our DV shelter can help with those kinds of resources. Or if they can't, then who can we identify in the community? And I think too, another challenge, I applaud your facility for having, great resources in place. Something that I've experienced in my own practice is, the area where I live, we have one hospital that serves about 13 counties. So if a patient who is, stalking a healthcare provider needs to receive care, even if there is a protection order in place, even if there is someone, even if security knows that this person, has been stalking a healthcare provider, there's nowhere else for them to go to receive care. And, our emergency departments can't turn a patient away. So, especially when they're the only emergency department for an hour or 2 hours. And, that's not unique to rural communities. There are lots of communities that, have those experiences. And, how do we navigate that? What can we have in place? And I think a big challenge in our facilities is that often there's not a policy, not a procedure, not anything in place to address this, because it just hasn't happened yet. And when it does happen, then we're kind of backtracking, trying to figure out, okay, how do we, what do we do from now
Yeah.
on?
Well, that's how a lot of policies get developed, right? Something
Right.
happens and then you need a policy for it. I will also say that I think this is going to take a lot of creativity, because I was fortunate that our hospital is large. Even on my night shift, I have 3 to 4 physicians on duty. So for us, it was easy. That physician cannot take care of that patient. So if that patient does present and that physician is present, any of the other physicians on duty, no matter where they are, because we have zoned areas, will take care of that patient for her, right? But if you're single coverage in a community hospital, or the, one of two nurses, it becomes a challenge. But I do think when these situations come up, that planning is the key. You need to involve directors and hospital attorneys and everybody else to come up with a plan of how do you mitigate the contact of that, of the stalker and the person being stalked, whether that's finding an additional nurse, calling in a different physician to care for the patient in the time frame, and that, which is still very challenging and may not always be the ideal situation because of federal laws and all of the emphasis, at least for hospital employees and ED employees, on metrics and patient experience and all that kind of stuff. But I think that is really you know a system response. I think you need to include all members, and law enforcement becomes a very big part of that. Like if you need to have your local law enforcement agency needs to be aware that, hey, this is happening and you never know what's going to happen, and you may need to be ready to respond to our hospital should something happen, and explain the situation better, that they're forewarned and aware of something before having to deal with it you know at the back end of it. So I do think that it, the challenges are there, the solutions can happen, but will take a lot of planning, safety planning for everybody, and then just a lot of people involved to understand what's going on. Which, once again, you know, when you look at victims' rights and that Like you're now telling a whole bunch of people that you are facing this problem. It's not something you necessarily want everybody to know about. Again, we don't identify, sexual assault survivors in the workplace. We don't identify, DV survivors. We don't know that people have that going on in their life, but because of the type of crime that this is, actually people need to know. Once again, making it a very difficult thing because you're now on display. How do your coworkers feel around you? How do your coworkers think about you? Do they have those same kind of things? So it really has to have a lot of education, even amongst your colleagues, about what's happening and what's involved with it.
Yeah, I can speak to some of this as well. Thank you, Ralph. I just want to underline the disbelief for me in my case. There were some of those systems in place in the small community where I was, and those systems did not work in supporting it at the time. And then when the stalking escalated and I finally did reach out to law enforcement, that was also not supported. I know now through other agencies who just said, what are the statutes in your state? And I think SPARC at some point has a great, US map, look on your state and see what the laws are in your state. Because they're all the same, but they're really not. And if you can't prove it, I couldn't prove it, I can't get a restraining order. So I go through years of legality to try to prove something that can't be proved. Why did I do it in the first place? Well, I go through this exercise of outing myself, of disclosing in the community, not just my work, my church, my family, my relationship, my kids, their teachers, everywhere now knows this. And having to change jobs several times, having to not have clients, having to change the clients that I take, change the treatment that I use. It affects everything. And I think those challenges, how about this? It's an ego gut check. Like, guess what? You're a provider, but you're a human too. And that person sees you as who they see you. And they will try to access you in any way, creative shape or form they can. And other people may recognize that or see that, but if there isn't a statute that supports it, it's on you to figure that out. And in my case, I reached out to a local women's domestic violence shelter. It took years to get there. I was like, I don't fit there. Well, I don't fit there. I'm a man. I don't fit there. And those advocates have been my lifesaver. Please come in, tell us your story. How can we support? We know that there are limitations, and someone's listening, someone's supporting. There are limitations, yet I appreciate that. Like, I'm still here. I'm still listening. Okay, how do we move forward? How do we safety plan at your house? How do we safety plan with your family? Yeah, big questions. Big questions. So,
Yeah, I think I want to add something here. I think it's so important that if just one person listens to you, just one person, hears what you're saying, and I'm gonna, tap on Jordan here. I reached out to her to, be a panelist on this webinar, and I was like, hey, do you have any particular knowledge about mental health nurses as victims of stalking? And her response to me was, yes, I do. Are you safe? She made sure that I was safe, that this wasn't hey, I need to talk about something and I don't know how to talk about it. That's what we should all be doing for each other, for our coworkers. And that stigma, that disbelief, it's there. People hear, what someone is saying is happening to them, and their gut reaction sometimes is to be like, no, that's not happening. And it is happening. It's a reality for the person that it's happening to. And, I think we can just start from the very beginning by just listening and not forming that first opinion, not, being just listening to what someone is telling us and, not having that bias, right? Because there's no textbook stalking victim, right? It happens across genders, it happens across races, it happens across socioeconomic statuses. There is no textbook victim. And there's just, we have got to push past that stigma that this doesn't happen to men. This doesn't happen to white people. This doesn't happen to people of a certain religion. It does. And we know that it does. And I think as healthcare providers, something that we can do for one another and to, help provide that support is just by facing that bias, by owning, like, maybe I've had these thoughts before and moving past it and listening to people that, come to us looking for support.
I think that's very well said, Lacey. And on top of that, a lot of times within the healthcare industry, we are so inundated with prioritizing safety for our patients. When does it come down to us? When are we prioritized? So I feel like that is such a challenge in itself. And that's basically the reason why we're here today, is to bring awareness that this indeed is happening within our industry. And it's time to prioritize us as well as the provider.
Yeah. Well, I think a lot of it has to do with the awareness as well, because I think if you went to a group of people and, gave a scenario of a former partner stalking somebody, everybody would understand that. I think they would all say, oh yeah, of course, I've seen TV shows about it. I've heard about it. I maybe experienced it myself from a person or that I was dating or involved with. But I guarantee that if you went to them and gave a snippet of the stories we heard here today and, tell them that the stalker is a patient or a client or that, they'd be like, no, that can't happen. They can't stalk you. And, I think that's, you know, worse if it's coming from people who are supposed to help you. So other licensed professionals or victim service agencies, if just think of the response if that DV organization said to you, well, wait, it's not domestic violence. Our name says domestic violence. Sorry, don't come in. Congratulations to them for being, forward enough in the field to realize that it does bleed over and it does happen. And wow, we probably are the only ones and the best ones in our community to talk to you and help you and work with you. Which, once again, sometimes if you're in a small community, your agency may not be that savvy or may not be that aware of it happening outside of the true DV sphere and may actually be a barrier as well.
Yeah, I just want to add, I mean, we at SPARC do a ton of training for victim services, and there's a lot more to be done. As for law enforcement as well, for any kind of responder, we always say at this point, you have to luck into a good response. And that's not how it should be, right? Every stalking survivor, no matter what their profession or any other characteristic that they have, should get that empathetic, trauma-informed and robust response, whether they're pursuing through a criminal justice angle, through victim services, etc. I did just want to voice that anyone, because I know we have a lot of victim service providers on the call, but that's if you are receiving federal funding and you work with survivors of domestic violence, sexual assault, you're also legally mandated to serve survivors of stalking. And that includes all survivors of stalking, intimate partner and non-intimate partner. But a lot of folks don't know that. It's not intuitive, right? Like if I'm being stalked by, an estranged coworker that was in the same hospital that I used to work at, it's like it's not very intuitive to pick up the phone and say, I'm going to Google, family violence services in my neighborhood. Like, why would that occur to me? But that's actually where the folks are who can help. And I'm glad, Ben, that they were able to help you, even with not being able to solve everything, to have that person listening. But I just want to kind of reflect that something that, quote unquote, should be happening. But of course, there's that lack of resources, training, etc., that can make it really hard to provide those comprehensive services for our responders. So for those folks who are on the call, what is something that you would like them to know? So if, of course, we want to know where to go, like you said, that's really difficult. But if we do raise that awareness of, okay, someone's experiencing stalking, no matter who that stalker is, let's talk to our domestic violence or sexual assault service providers. What would you like those folks to understand better about stalking in healthcare spaces?
I mean, I'll go for this. I could write a lot about this. I mean, listen and believe. We've already said that, but really listen and allow that allow that context to show itself. I know context is a big part of the Spark training, and I might add, Dana, that you say you're not providing direct services, but in a way you are, because the trainings that Spark and other agencies like you around the world actually provide trainings as well. They listen and they believe, and you provide the information that I didn't have. I didn't get in grad school. I'm not getting this from my CEUs every year in ethics, and I have to go every year and sit in them. So listening and believing and taking someone seriously, that this little story that might not be the big story in the day of someone sharing might actually be the big story. And that client or person is waiting for us to go, oh, tell me more about that. I'm not going to judge you, but maybe that coffee cup on your desk means something that other people just dismiss. And that fear is debilitating, and I minimize everything because of it. I'm not worthy of it. So why would I reach out? It hasn't worked before. And so I guess I'd want them to listen and work through the stigma. It is a vulnerable place that's kind of messy and nasty to be in. And it is, again, I'm supposed to know it because I'm the healthcare provider still doing the work. The context is key. So knowing the laws and knowing where the boundaries are great, but it's also having that, as Lacey said, having that one person. And I can go and they say, would you like a cup of tea? Do you have a safe place? Did you get home? Text me. I had an advocate say, text me when you get home. And I just cried. I was like, why would you care? And I was like, oh, you get it. Yeah, text me. I'll text you when I get home. And then to go do that work the next day with the clients that we see, knowing what we now know, go, oh, wow, this is way more pervasive than I knew before. And clients may minimize it and say, nah, it's fine. And having to live with that. So I'm an advocate for finding things that work for yourself, and that might be out of the book. I agree with Ralph. Those have to be very creative. This is not going down the street and there's my service provider. It's going to be have to creative in order to support yourself and your family.
Yeah, I'll add, I think, something that I would want other, those first responders, mental health professionals, law enforcement to understand is that there are serious physical and mental health consequences associated with stalking. And, it may be that we, as the healthcare provider, have, a patient or, another healthcare provider that comes in as a patient that is telling us about these symptoms that they're having, physical symptoms. Maybe they're having chronic pain, maybe they're not sleeping well. And if we don't really talk and get to the root of what might be causing those chronic health issues, then we may never ever get to the root issue of, maybe this person is being stalked. And we don't really have a great way to do that right now. Some that we're working on how to talk with patients about this, but, you know, understanding that there are so many layers to any kind of situation that a person is experiencing, especially for those first responders that are, that first person to talk to someone after a traumatic experience. I think, if someone is calling law enforcement or calling for, emergency medical services, they have gotten to a point where they feel like they need help, and really being empathetic and understanding that, there are so many health consequences associated with this, and how we speak to these patients, to this person that we've come into contact with, is so important. I think, we use that term trauma informed care. It's a big, I always call it a buzzword. It's a hot topic, but in nursing school and, training for all of these other professions, we aren't necessarily taught how to do trauma informed care. We aren't necessarily taught how to have conversations about difficult things in a trauma informed way. And it's so important that if we weren't taught that and we want to know, that we seek out that information and try to figure that out, how to do that. It's not something that we just intuitively know how to do, right? So, I think that would be something that I would really want law enforcement, victim services, mental health to, to really think about, is how do we do trauma-informed care, and how do we get to the root cause of, whatever this issue is.
I think what goes hand in hand with trauma-informed care is going to be the idea of utilizing therapeutic communication. Because at a time where you are coming forward at your most vulnerable moments, you want someone to utilize therapeutic communication so that they are actively listening to you. So my hope would be that all of these interdisciplinary team members can utilize trauma-informed care while using therapeutic communication to make sure that you are safe and comfortable, because you're already going to be very uncomfortable at the forefront.
Yeah.
Absolutely. Anything else folks want to add? So what I'm
Mm.
hearing is, okay, we have this big issue. We know that there's a lot of stigma around it. There's a lot of disbelief. If we can find just one person, hopefully more, to really listen and validate the concern, whether that person is an official responder or a friend or a somebody, right? That is a colleague who maybe who's going to take it really seriously and help get you to help, and also some awareness about where that help is, because it's not always clear who you should talk to about this. So I'm curious, and this is one of my last questions here, and then I'll see if audience has any questions. A couple have come in. When you think to your current or past places of work, and like we've seen, we have folks in big hospitals as well as in private practice in their home. There's a big range here. Obviously, healthcare is really broad. What are current policies or practices that are kind of either actually happening or supposed to be happening around what do you do when a patient or someone else is crossing a line in that medical space? What has been helpful in addressing this problem, either for you or for folks that you've worked with, and what could be helpful? What would you like to see healthcare spaces be doing differently around addressing stalking of providers?
I just happened to see a comment in the chat that said, I've seen first responders and some medical providers get jaded and forget about trauma-informed care. And,
Mhm.
I think, yes, we do get jaded. We get burnt out, and we can't really provide a great response to any kind of violence if we are not, our systems, our facilities are not prioritizing staff mental health and well-being. We need that in place. We need the training and education, of course, about this issue, about stalking, about other forms of violence, but we also need to have our own mental health care and our own physical health, our own well-being taken care of in order to provide any kind of trauma-informed care to patients.
Yeah.
Yeah, and I think a lot of it starts at the system level if you're in a system, to look at it and make sure your policies are aligned to include stalking. It may not be there. And I think when you think of it or need to look it up, you need to have policies that are very clear of what they entail and what they cover. So you may need to add stalking to the title and then put a whole section in about it so people know what to do and how to act and how to respond and who should be involved. And then I think, if you want to be even a stronger system, probably set up that roadmap for when an employee comes to you about, being stalked, and say, oh, okay, well, we have a team dedicated to, ensuring your workplace safety. And what do we need to help you with? And how do we respond? And, you know, a lot of times that's not the person you may go to, but at least as a leader of an organization, whether that's, you know, departmental level, system level, et cetera, everybody should know how to access the policy and the people who are expert. But sadly, we don't often have, I think it was brought up earlier, but there may not be a policy. There may not be the guidance, and then you're stuck again. So, I think you have to look at this as a multi-pronged approach to how to respond as a system, what needs to be in place, how to respond as an individual, how to respond as a colleague, how to be trauma informed, and that. And, we always are doers. People in healthcare tend to want to solve the problem of whatever's in front of them in the moment. Sometimes that may not be solvable, but you could at least listen. and be supportive. And that may be the biggest thing that will help in the moment. So I think just having the education around this, like Lacey mentioned as well, to a variety of people is very helpful. And remember that these things, and I'm not meaning it as a minimizing it, like it doesn't always happen Monday through Friday, 8 to 4. A lot of health systems are 24/7 operations. And I can guarantee that at 3 in the morning on a Saturday, not everybody's going to know what to do or what to respond or who to call, et cetera. So another reason why everything needs to be really just clearly put in a policy or, a handbook so people actually know what to do so as to not cause harm right from the start.
In my situation, we did not have a policy, and I was at my wit's end. I was looking and looking through our handbook, our policies, our procedures. There was absolutely nothing. So it took over 2 years, and finally, we created a task force of interdisciplinary members. And that's whenever we came together and we created that policy. But it did take some time, and it took a lot of effort as well to have everyone on board and bring awareness.
Yeah, I think those when we create those forces, right? Like it's so important that the people that are chosen to be on those task forces are invested in solving the problem, right? And that the people that are on the task forces understand the scope of the problem, that they've had that education about stalking and they're invested in trying to come up with a solution. I think a lot of times we hear the word task force and we kind of glaze over a little bit because there are so many task forces, so many committees that we have to do and that we're a part of. But we really want people in these types of situations to be on a task force because they want to be and because they're invested in solving this problem.
And I might add, I appreciate this, the continuity of care across the systems. So it's like, I want to go work for you, Ralph. You have an awesome system, right? But then I go, oh, well, now I'm in the public sphere of the police department, or my friend who's a lawyer or a social worker, whoever that is, they don't have any of this in place. Do they have the education? Does my alma mater graduate school like teach this? Do they know what a SPARC log is? Do they know what the sharp is and when that might be appropriate to use it? And even with some of my clients, like I love the SPARC log. I mean, I thank my first advocate for showing me what that was, because then I had to realize I needed to take that on. Nobody else is going to do that. And that's a job. And how do I have self-care in order to manage that in my professional and my personal life? Because I might excel in that clinically, but as soon as I take that hat off, I'm a train wreck going home, still wondering about where I'm going to buy milk for the night. So the education has to be everywhere. I hate to say it, even in the school system, because then I see that in the kids that I see, and they're oblivious to it. That's just how it is, man. No, it's not. Oh, I should write that down. I could talk about that. Yeah. Oh, maybe I should take notice of this. Maybe I should speak up. Maybe it would be okay to talk to somebody else. It doesn't have to be me. You could trust another person. They may be a healthcare provider. They might be your minister. They might be the grocery clerk. I don't know who they might be. I think it's the destigmatization of it is key for me. The policies are great. My current job doesn't have any of them. We don't have any policies around them. I feel like I'm the walking policy. But then at home, how do I manage that policy of being with my family? So multi-pronged in many ways. I appreciate that, Lacey. How do I take care of myself? That's hard to
Yeah.
do. Yeah.
Yeah. And to your point, making sure it's not just the clinicians that are receiving the education and training. It's everyone that a patient will touch when they come into a care facility, from the receptionist to the environmental services staff to the folks that are working in the kitchens and passing out patient trays, things like that. Like, and not only just the education and training, but understanding that statistically a lot of these people that work in these facilities will have experienced some kind of violence in their lifetime. And talking about these things might be triggering for them. So when we're talking about it, providing that direct support, not just, hey, here's the number to EAP. Let's facilitate, make sure that if anybody's having any kind of, thoughts or they're triggered by any of this, that we can connect you directly to someone to speak with, giving people just a heads up, hey, we're going to be talking about stalking today. So that if they have something that they need to handle, that they can handle it before they come in. Like I know for me, it's really helpful when I know if I'm going into a training that we're going to be talking about intimate partner violence, something that I've experienced in my personal life that I need to mentally prepare to speak about. And I think just those small things that we can do with all of, the people that are going to touch a patient can be really helpful and help people invest in really taking care of these patients, victims, survivors that we're going to come into contact with.
Yeah, and just to summarize, it sounds like there's so many things, right? There's the formal policy. There's let's have an actual policy and protocol, and then let's make sure it's followed, that the right people are involved in it. And certainly policies and protocols don't solve everything, right? I would not say that they do, but I would say, generally one of my many soapboxes on stalking is, just about every workplace has some kind of harassment training. Well, when does harassment become stalking, and could that be named, and could we have a little bit more awareness of that just in a workplace setting, and when does all of that. I just feel like there's so much missing in terms of just having, in any workplace, frankly, not in some workplaces do it, but in many workplaces there's not that clear policy protocol. I do control F stalking on so many websites, and I find nothing, even though I know that the people who are involved in that workplace have certainly experienced that at similar rates as sexual and intimate partner violence. And then there's the informal piece, that sense of when I go to my religious community, when I talk to my colleague informally about this, when I tell my friend about it, do they have any idea what I'm talking about? Right? And that's going to come up for our medical providers who are victims, as well as for any victim or survivor. And I would think also, just from what I've seen, how the way people talk about stalking survivors, there's sometimes a sense of medical providers is like very powerful. So there's like, they're a doctor, they're fine, they're like, they're smart. They must be smart if they went to all that nursing school. There's no way that they would, and that kind of victim blaming and minimization about who can be a victim and who isn't a victim. And so I think a sensitivity to that as well, both inside the healthcare space as well as in the broader community. So we have just a few minutes left. I have a couple audience questions here, but I did want to just kind of give you all an opportunity to say anything else. Is there anything else that you're thinking, I wish people knew this, or I didn't quite get to voice this and I'd like to? Because I want to make sure that you have the platform, have the floor. So is there anything else folks want to voice? No, you said it all. That's fine. Not everyone
Well,
needs to. Yeah, go,
yeah,
go, Ben, go. Yeah.
I want to circle back to what I think you started with about stalking and just underline the fear. That the fear is real, and having to prove that I am afraid for my life. Not just afraid of the scary spider, but I am afraid for my life or my family's life or well-being, and that I would have to prove that to a boss, coworker, state trooper, or someone in order to get a restraining order or something, and to have that fail. That's real, and it doesn't go away, even if the case simmers down, and that we ourselves may experience post-traumatic stress. And again, attending these panels and seminars is so helpful. There are others around the world that also do them. They can be very helpful. And sometimes also knowing when something doesn't work, and it's okay not to do it. It's okay to say, this doesn't fit me, regardless of what the title is on the policy of the person who has it. So again, I'm very appreciative and grateful for this discussion. I've been waiting for this discussion for a very long time. So I'm very appreciative of being here today, because I do think it needs to be taught in schools and in graduate schools. And it'll be a challenge to do so, but I think the education piece is big for me.
Yeah, I totally echo everything you said there. And, I think important when we're thinking about these policies and procedures, when we're thinking about doing education, doing community outreach, any of those things, that we're incorporating survivor voices into everything that we do, into our policies and procedures, into our education and training. If we don't have the perspective of a survivor or multiple survivors, then how are we really serving survivors? You know, having that voice is paramount when we're doing this work.
Anything else folks want to voice? All right, well, we just have a few minutes left here. I will ask one of the audience questions and then I'll wrap up. Of course, our focus today is on stalking of healthcare providers, but somebody asked, have you seen this happen in a reverse fashion? So you have a healthcare provider have countertransference towards a patient because they have all that personal information. They have some power in that situation. They're saying they know someone who married past patients and kind of ran into them outside the hospital and that kind of thing. So just curious if you've seen that dynamic at play.
Yes.
Okay.
Most of
It can affect everyone, even, my colleagues, my peers, we're still humans too. And we have our own mental health issues as well. Substance issues, you name it, that can easily happen. And that's why there are ethics boards and that's why there are policies and procedures. It does happen. How often do we hear about it? Probably not very much, but yeah, it happens.
Yeah, and we know some stalkers are those, we call them people of authority, and that could include a medical provider or someone that, they're under their care.
Yeah.
All right, so I'm going to pull back up our BioSigns logo and my information. And if you have further questions for the panelists today, feel free, let me just put my information up here and you can contact me and I will pass it along to them. I do want to say, hearing about people really need education on this, I'm like, yes, that's I'm the senior training and awareness specialist at the Stalking Prevention Awareness Resource Center. And we're so passionate about educating folks on stalking. And I can tell you, in every field, just anecdotally, I mean, I usually start my training by asking, is this the first time you've had the opportunity to attend a training specifically on the topic of stalking? Usually half of the whole room raises their hands. That's whether it's cancer professionals, victim services, law enforcement. It really is an undertrained issue. And again, there's no one thing that solves everything, right? A policy doesn't solve everything. A training doesn't solve every problem. But to hear from you all how much you wish there's just more education and awareness, both at the official level and those official response systems, as well as those informal responders. And so, I do just want to flag that we have a lot of resources for that. We have fact sheets, infographics, short informational videos. January is National Stalking Awareness Month. So whatever kind of workplace you're in, to do a quick lunch and learn, to watch a video, to have a table with an infographic. Again, not saying that solves everything, but there really are some resources available. And it really takes all of us to be advocates for this issue because most folks don't quite get it, right? And so I'm really thankful to the panelists for making sure that the people on this call and for everyone who joined taking an interest in this issue. We know we're in a overwhelming time with a lot of competing issues, but stalking of healthcare providers needs to be on our radar, but it needs to be something that we're addressing. And so I just, again, don't hesitate to contact me for any further questions, for further training on stalking, etc. Or if you'd like to reach any of the panelists, I'm happy to pass it along to them. I really want to thank the panelists so much for your incredible insight, for all the work that you do for patients every day and the amount of care that you provide, as well as for being so open and vulnerable and honest about this topic that I know we have survivors on this panel. We have folks who have experienced this, and it's difficult. It's difficult to talk about and to share that vulnerability, but it helps us so much to hear your voices and to hear your very thoughtful responses about how does this issue present? How does it impact healthcare providers? And what can we start to do about it? And I'm hoping this conversation is just the beginning of improving the response. So truly thank you for all the work that you do and for being a part of this. It's an honor to be talking to all of you and to have you all on the call. So thanks so much. We're just at time here, so I will conclude. Don't hesitate to reach out for resources, training, anything like that. And please stay tuned for all of SPARC's work and especially our vital signs work on enhancing the healthcare response to stalking. So thank you all so much. Thanks so much to Lacey, Ralph, Jordan, and Ben, and for all of you for joining. But I hope to see you all again at a training soon.
Thank you.